Hi, friends.
Hello.
Out of respect for your time, we'll go ahead and get started. And I want to thank you so much for coming out today for our impromptu Hospice and Palliative Care seminar. We had a seminar in October where we talked about in-home care. We talked about the different types of in-home care, and there were questions on the surveys that we received about hospice and palliative care. So I see these friends often, and I was like, hey, let's do a workshop or a seminar on hospice and palliative care. So thank you for your recommendations and bringing this topic to life today. My name is Lee Ann Balta, and I am a downsizing coach with the Balta Bautista team. And we are at the Century 21 Sheets office in Zionsville. And then you also see in the back of the room our education partners, for which without them, we would not even be here. So thank you to our education partners, and please, are you flipping that or am I?
Yeah, you forgot, so I was clicking in here.
I love you so much. Thank you. Everybody deserves to have a Betsy. So these are our education partners, and we are here to educate, empower, and so please see them if you have any further questions. All right. What you have on your chairs today is a notebook, because I'm going to ask the beautiful lady some questions, and then I will open it up for questions from our guests. And so you can jot down any notes in your little notebook and pen. And then you also have a flyer for the next seminar in December. We're going to talk about the journey of downsizing part 2, which is the actual process of moving, that packing, moving, unpacking process that we like to make easy for our clients. And then you have a blue survey. Please fill out your surveys before you leave with any kind compliments or recommendations or improvements. You help us be better. So don't leave without filling out those surveys. All right. Some things I want you to know about before we get started are where the restrooms are. They are out this door. Take a quick left and a long right, and you will walk into the restrooms. And then I already went over the materials in your chairs. I have some prepared questions for the ladies, and then we're going to ask your questions. We'll wrap up at 11:30, unless we run out of questions. And then just wanted to remind you to connect with our education partners afterwards. And then yes, we're here to educate and empower. This series came about through life changes. We're getting older, our spirit is getting older, our clients are getting older, lots of questions, which led Betsy and I to use one of the skills that we have best, which is the organizational skills. So we thought, we have questions, let's organize a seminar series and start to get answers to those questions. So that's why we're all here today. That is our agenda. Any questions before we get started? All right. Well, I'm going to let the ladies introduce themselves. They're going to tell you their names. They're going to tell you who they're with, and then maybe just a little bit about what led you to the field that you're in. Yeah. Let's do that. Let's start with Jennifer.
Hi, I'm Jennifer. Jennifer Lovell-Lenbaum. I am the Director of Marketing and the Volunteer Coordinator for Dignity and Hope Hospice. And if you could see my resume, you would just sit there and be like, how in the world did she end up in hospice? I have a corporate background. I was with Monster.com and Radio Disney and all of the stuff, if you will, and having the time of my life. And I'm at the point in my life where I made the decision that I wanted to make a difference in the lives of others. I can remember where I was sitting. I was in a sales meeting for a radio station, and I was like, I'm not helping anybody. I want to help others. So I worked for the Alzheimer's Association for almost 5 years. And then the doctor recommended that my mom be put on hospice care. And our first experience with hospice care was horrible. And we, at that point, I had had lunch with a friend who was also in hospice at that time. And she's like, Jennifer, I don't care if you go with my company, but you need to find a company that's right for you. And I'm telling you what, when we switched hospice companies, cannot imagine the end of my mom's life without them. And so that was when I was presented with this opportunity, and so I have committed, along with my peers my colleagues that I work with, that we don't want any family to go through the hospice experience that I went through in the beginning. We want it to be a good experience for those that are at the end of life's journey in their families.
I think when I Googled you to get your headshot, I came across I think a networking that, something to the effect of don't bother trying to recruit me or something like that. Do you remember putting that out there?
Oh, Not for Hire.
Yes.
That was the company that I had started
Yeah.
a while back called Not for Hire.
Susan.
Thanks for the opportunity, Lee Ann. My name's Sue Humphrey. I am currently with Community Health Network Hospice. I am similar to Jennifer, that I have a very varied background, but I started my hospice journey about 18 years ago as a hospice volunteer. And to be honest with you, I went kind of kicking and screaming because I didn't know what hospice was. I had the very common misconception that, it's just, all about you're sitting there laying in bed, they're giving you shots, and boom, you're done. And that's kind of what I thought, so I was like, no, I can't do that. I cry at a good commercial. I'll be crying all the time, So the friend of mine was a chaplain at hospice that had just opened in the Indianapolis area, and he talked me into becoming a volunteer, and I went through the volunteer training, and I fell in love with the mission, and it was just so moving for me. I sold my business and I got into the hospice business, got hired. I was a volunteer director, did bereavement coordinating, and then moved on from there. But it was amazing. I got my first patient, and it didn't hurt that she was like Maxine from the cartoon. And I got to go with her from when she was in assisted living to long-term care until her very end, and I met her family, and I realized what a blessing it was for the patient and for the family, for her, and I stayed in touch with them, and it really changed me as a human being, and just as Jennifer, I felt this is what I want to do. I want to let other people, I want to educate other people on what that opportunity is, that people don't even know that it's a benefit that they're entitled to through their Medicare. So that's a little bit of background about me.
Well, thank you for that. All right, Miss Kate.
Hi, I'm Kate. Chars is how you say it. I found a Polish unicorn. He had all kinds of unnecessary vows, but he was worth every single one. That's what I tell people. Thank you for this opportunity and getting to know you. Doesn't she have the best hair ever? Okay. Well, all in agreement. Beautiful, Lee Ann, beautiful. How I got into hospice, I always say that hospice is a calling. It's not a job, especially I feel like my arrival in hospice was very similar to these two. I tell people I prayed myself into hospice. In 2014, I had a very radical come to Jesus, and I'm very vocal about how I got here because life is hard. And so I tell people that in 2014, I landed on my bathroom floor and I didn't want to be here anymore. And I said, if you want me to stick around, then I'm going to need your help. And in that moment, I had to come to Jesus, is what I say. And he saved my life. And so as I went through this transformation in my own experience, I really pressed into him and I said, well, what is it that you want me to do and why did you keep me around? And he says, you're going to go and love on people, Kate, in the same capacity that I found you on your bathroom floor. And you're going to meet people where maybe they're hopeless or full of despair and they don't know what to do, and you're just going to show up and be their hands and feet and love them through that. And I thought, well, that's great, but what capacity? And so I tell people I prayed myself into hospice without knowing that I was praying myself into hospice. Hospice is very severe because nobody wants it. Who here is excited about this conversation? Right? Nobody? But you know, there are two certainties in life, and that is paying your taxes if you live here in America, and that is death. And nobody talks about it. Everybody wants to avoid it like they can escape it. And unfortunately, that's just not the way life works. And so you're going to have to come up against this rub, whether you want to or not. And there is a right way of doing it and a wrong way of doing it, in my personal opinion. As far as my background, I've been in the C-suite. I've been in healthcare for over 10 years. I have done multiple things. Legacy Hospice is my own creation. I created it. I launched it in 2024, and that was something that is God-breathed. And I'm passionate about what I do. I'm passionate about loving on people and loving on them really, really, really well. But that's how I got here. And then I met beautiful Lee Ann, just met Betsy. And so I'm honored to be here to speak on behalf of Hospice and Palliative.
Thank you so much, ladies, for being here. And on pretty short notice too, so.
We wanna know why have you been keeping Betsy in the corner?
I-
We see Lee Ann out and about.
There's a reason for that. I don't want to show her off. Everybody in my office already calls her my Betsy, and I just don't want anybody else to know about her.
I'm her closet, Betsy. No.
And again, I just want to thank you all for being here because, you know, over the next few years, you're going to have friends that are going to go through this process, and we're all going to be better equipped for having had this conversation. So thank you for being so generous with your time. All right. Well, we're gonna talk to Miss Sue first. We're gonna talk about palliative care first. Will you tell us what is palliative care?
Okay.
Maybe how that's different from hospice. We're gonna get into hospice, but
Sure.
yeah.
Palliative care is a precursor to hospice, really. And it can be accessed, or really should be accessed, anytime that you have, or somebody, your loved one, or whoever, gets a diagnosis of a life-limiting illness. Or the difference, you know, with hospice, to qualify for hospice, your life expectancy is usually 6 months or less, you know, to qualify for a hospice benefit. With palliative care, it's more like 24 months to 18 months, something of that nature. But the biggest difference with that is that it's you can still seek curative treatment while you're getting palliative care. So palliative care is like a specialty doc, like a cardiologist or pulmonologist or something like that. So if, you know, God forbid you were to get a diagnosis, or somebody that you know gets a diagnosis that's life-limiting, then I highly recommend seeking out a referral for palliative care, because it's really basically symptom management along with the care that you're getting from your specialist. So it would take care of pain management. It takes care of, you know, breathing issues, anything like that, really.
I was gonna ask, life limiting, like, the examples of that.
Well, let's say you have
Cancer is a good one.
Cancer is a good one, yeah.
Dialysis.
Dialysis patients, somebody who is a Parkinson's patient, an Alzheimer's patient, those types of diseases, you know, they're life limiting, right? But they're not necessarily hospice appropriate yet, because their life expectancy is longer than 6 months, right? But they could use that extra benefit. Now, palliative care is not as involved as hospice. You don't get the home visits like you do with hospice. But in a lot of times you will go to a palliative clinic to go, it's just like I said, it'd be like seeing a specialist, you know, like you're going to your oncologist. And then they would write prescriptions. Now, sometimes if you have a loved one that's in let's say a nursing home, okay, and they're pre-hospice appropriate, they might have palliative in the building, where they come in every 2 weeks or once a month, and they can also manage symptoms before somebody is hospice appropriate. Really, that's the beauty of hospice and palliative care actually too, is they come to you if necessary, right?
So sometimes palliative care does go to?
Yes, I know community has ability to go see patients in their home, has, in assisted living, in long-term care, or, they can come to the clinic. Whatever's most beneficial for that patient. They have a program called PATH. Now, I have to give you a caveat here, I'm not super familiar with the community resources as of yet, because I don't really start until the 12/1.
She's waiting right now. She's caught her in between.
Yeah.
Transition.
I'm in a transition, but I talked to Nita Rikas, who is over the, what do you call it, post-acute care, and she shared that with me, that they have all of those resources available to you. And that's the biggest difference, is that you can still seek curative treatment while you're on palliative care. Whereas when you go on to hospice care, at that point you make a decision on whether, does it make sense to continue certain treatments, if you're not getting any therapeutic benefit anymore, do you wanna put yourself through, chemo or dialysis or whatever, because eventually dialysis is a great example, really, because you look at it and think to yourself, okay, if I stop dialysis, I'm gonna die, right? But as time goes on, dialysis becomes less effective and takes more toll on the body. So that's definitely a personal decision, but something to keep in mind, right? Parkinson's, Alzheimer's, I think those are two disease groups, or anything neurological, really. ALS is another great example. If you have a loved one or a friend that's suffering from one of those diseases, as soon as they can get into any of those types of programs to take advantage of the benefits, the better. Why not, right? Palliative care is, like I said, like a specialist, is usually covered through your insurance, like any other specialist would be covered. Whereas, and I know you'll get into it more later, where hospice, once you decide to switch to hospice, that is a benefit that's covered through your Medicare 100%. There's no out-of-pocket costs, there's no co-pays, anything of that nature. But I'm sure we'll get into that more, yeah.
Yeah, good. Okay, so palliative care is typically through our insurance.
Yes.
Part B, it's a consultative.
Yeah.
Okay.
So your hospice is gonna be through Part A,
Right.
your palliative is going to be through Part B.
Okay.
Yeah. Or private insurance, whatever you have, or Medicaid, either one, any of those.
Can I say one quick thing
Yeah,
about,
please.
so there's a similarity with hospice and palliative, because both focus on comfort care and quality of life. The difference is, as she said, with palliative care, you can still seek curative treatments. So that's kind of like that fine line. So when you're no longer seeking those curative treatments, maybe the risk outweigh the benefit type of situation, and that's where hospice comes into play. So both of them focus on comfort as well as quality of life.
Yeah, well put, Jeff.
Yeah, comfort and quality of life. Okay. So it's palliative care supports you comfortably as you're living, as you're. All right. You talked about how the cost of it. Let's go ahead and transition a little to hospice care. Kate, tell me about hospice and who's eligible for hospice.
I always define hospice a little bit different than maybe what you would look up on your AI components. I always say that hospice, typically, if I were going to use that definition, it would be where two physicians would say that you've got a terminal illness that is 6 months or less. I kind of put that on the back burner. I say hospice is just additional TLC, period. What we do in the hospice realm is somebody has been diagnosed with a terminal diagnosis, and at that point, that's when you determine what's better fit for you versus palliative versus hospice, all depending on what your goals are in that moment. So if, for example, I like to use examples, real life illustrations. I met with a Korean vet, 94 years old, and he has ulcers all over his esophagus, and he's got, his body is failing him and his mind is sharp. And he's been going in and out of St. Vincent's multiple times, multiple hospitalizations, and his daughter is his health giver or caregiver. So I meet with them, and basically what I learn is that he is tired of going into the hospital all the time. Like, he's tired of it. They're not coming up with any cures, It's being poked and prodded, he's falling, his quality of life is in a hospital when really he wants to be at home. And so that's the time that we have the conversation. What are your goals? And because he's got so many different declines in so many different areas of his life or in his body, that he would be a senile degeneration, or he would be another diagnosis that just takes the decline in all of the organs that he's undergoing. But do you see what I'm saying? Like, doctors can tell you all day long that it can be a 6 month or less. God only knows that time. We have people that recertify for hospice after every benefit period regularly. Are they scrutinized by Medicare? Yeah, maybe. But as long as there's a continuous decline, they're still eligible. And that's our responsibility, to be able to gather all of that information and then be your advocate when it comes to this, because this is what hospice is. People want to, kind of stiff arm the hospice benefit, and I'm like, oh no, the sooner the better. The sooner the better. You get a whole interdisciplinary team. This is also a big differentiator between palliative and hospice. When I meet families and they're like, well, I don't know what to do, I first start with, well, what are your goals? Okay, because that's going to define very quickly which arm they want. But if they are tired of aggressive treatment, or they do not want to go to the hospital anymore, and they want to remain in the comfort of their home, then they are probably going to qualify for the hospice benefit, depending on what's going on within their illnesses. But to caveat on that, you've got a whole interdisciplinary medical director, RN case managers, CNAs, you've got social workers or resource supporters, counselors, bereavement, chaplains. That all comes in this huge IDT team that comes in, and we just love you guys. We just wrap you up, and you guys get to determine your cadence. You get to determine how often you see us. You get to determine, you get the control in this. Palliative, on the other hand, you're gonna have a nurse practitioner and an LCSW if it's done well, and they're maybe gonna see you once a month. Maybe, but you still get the pain management, and you still get the resources that they can offer, but it's just a much more rich benefit with hospice. The other thing that I love to talk about hospice is to get some contribution from you guys. What are the myths out there regarding hospice? Like, we do not just walk in and discontinue all of your meds. That's an urban legend. We do not just put you in a corner and pump you up with morphine. Like, there are all kinds of scenarios that I get asked about regarding the hospice benefit that are farce. My Korean thought everybody was gonna come and live in his home. Then I'm like, no, we don't come into your home, but we do visits. And so this is a very important aspect of hospice. Hospice is not 24 hours, 7 days a week, having somebody at your bedside. You've got levels of care of hospice. So if you've got some sort of critical pain management that can't be controlled, we would increase that to a continuous care case where you would have an RN around your bed. But typically, we're just 45 minutes to an hour of time that we come in and we serve you, and then we get out of your hair, unless you need us a little bit longer, and then we have that conversation. You know when we're coming in. You should know when we're coming in.
Okay, a lot of people think that hospice hastens death. So how would you answer that?
I would say, actually, hospice prolongs death. And you can look at the statistics, and if people continue to go down the route that Western Hemisphere medical groups often push, then you're going to hasten your life, because the body is a remarkable instrument. And as soon as you allow peace and comfort to your soul and your mind, then you rest, and then your body is able to naturally do what it's supposed to do. That's proven fact. 80% longer, you live longer, 80% of the time longer if you were on hospice as opposed to continuing treatment within the medical system.
Yeah, it's really there, hospice isn't really there to hasten or prolong. It's there to support the natural process. We don't do anything in hospice, and yes, her statistics are correct. You do live longer when you have that extra TLC.
Peace.
Yeah. And one of the things that I wanted to mention was that you get to be in the setting of your choice. Especially if you make your decision early enough. Sometimes things happen and, you are not able to stay at home due to the acuity of your illness, you know, just depending. And that's where I think a difference comes in between a hospital-based hospice or a private hospice. Sometimes with hospital, you know, or should be with all hospital-based hospices, you're able to go into a hospital setting for a determined amount of time and change your level of care to what we call general inpatient level of care. And that is where your symptoms are not able to be managed at home. You know, let's say you have need for medication every hour or every 2 hours, or you need like a pump or a pain pump or something like that. That would be a reason to have to go into a hospital type setting. And it's too much for a caregiver to have to give a medication once an hour, because like Kate said, we're not there 24/7. And there is a lot of stuff that the family has to do. But I think that's part of the beauty of hospice again, is because I mean, we all kind of, you know, when we're with a partner or with a parent or a sibling or anything of that nature, you know, we've kind of made that commitment. We're there for them. We're family. We want to take care of them when they're at their most vulnerable, right? So, but hospice gives you that opportunity to do that at home, you know, without having to go into a nursing home necessarily, and not just because of the fact that it's a nursing home, not that there's anything wrong with that, but it's not home. It's not like being in your own bed, being surrounded by your things and your loved ones and so forth. So if you're able to do that, you know, the sooner you can make that decision, the better.
The other thing that I want to add is it's not just visits that you receive through your hospice benefit. It is such a rich benefit.
I was gonna ask, how does that help families?
So in addition to all of the visits, this is another thing. So typically when I go meet families and we're on the verge of palliative or hospice, then I'll give them the whole package of both without giving any identity to what the benefit is. But with your hospice benefit, you receive all of these interdisciplinary team focus, all professionals, and you get your durable medical equipment. So a hospital bed, and over the bed table, your oxygen, your nebulizers, all of your meds that are related to your primary diagnosis, those are all paid for under the hospice benefit. If you've got a parent or a friend that's incontinent, all of your incontinence supplies are covered by the hospice benefit. You guys do not have to absorb that yourself anymore. I see people scavenge for DME, and they're like, where can I get a hospital bed? And I'm like, I will have it delivered tomorrow, just get your bed broken down. Like, we are a lifeline that you don't know that you necessarily need until you find it.
Lee, can I,
Yeah.
so the interdisciplinary group, I get so excited about this. I made a fun little diagram. I don't even have the diagram back there. It's in the brochure. But it's a team. And that team is dedicated to the patient and the family. And that's where, like my dad, he was the kind of guy who was like, I don't need, support, All said and done, he needed the support. So the social worker, I get really excited talking about the social worker, because there are some generations where that wife cooked every meal, and so the husband is home alone now because the wife is on hospice. He's not alone, but he's now in charge of his own meals, and he's eating lunch meat sandwiches because he knows nothing else. Our social worker connect them to food resources that can give him a hot meal. Or we have a patient where the wife and the daughter and the mom, they were having a lot of headbutting, and mom couldn't find peace, and the daughter couldn't find peace. And the mom could not think about her end of life not being at peace with her daughter. So we were able to bring in family counseling. And so mom just recently passed 2 weeks ago, and she died knowing that there was resolution between her and her daughter in the conflict. There's also a chaplain, and a lot of people say, well, I'm not a religious person, or what if I have a different religion than, what the chaplain. We have community resources.
What the chaplain?
Are you the chaplain back there?
Yes.
Hey, chaplain. So if you don't have that sense, we have community resources. And also keep in mind that spirituality is more than just religion. There's other parts of spirituality. So we can help kind of fill that gap. And even if someone doesn't attend church regularly, sometimes at the end of life, their faith starts to come out a little bit more, and we can have that dialogue with him. And so we're not condemning everybody to hell with our chaplain. That's not what the chaplain's all about.
Nope.
He also helps the family, because even though the loved one hasn't passed, they're still, they're grieving. This isn't the mom or the dad or the loved one that I remember. So we can help them through that grief process and let them know that grief is normal. There's dietitians. So if, we need a dietitian to help make sure there's comfort. Physical therapy. We have physical therapy, occupational therapy. So there's this whole interdisciplinary team focused on the patient and the family. And hospice doesn't end at death. There's also a bereavement period for 13 months following death. My dad's like, I'm cool. I don't need bereavement. Well, you know what? He needs the bereavement, and he's very appreciative of what he's getting from our hospice company after my mom's passing. So, and then if you're wondering why we're not all doom and gloom up here, a lot of people are like, hospice, and they get real somber. We are so honored to be able to provide end-of-life support. It's an honor to us, it's an honor to our colleagues, because there's two things. She said paying taxes and death. Well, also, everybody's born, and think when a baby's born, we all celebrate and we get excited about a birth. Well, we're all gonna pass. So let's celebrate the life that all of us have had or our loved ones have had. So please don't think that we are in any way being disrespectful to the death process, because you know what? Life is beautiful, and death can be just as beautiful as well.
Thank you, that's wonderful.
Leanne's
I really
like, pressure
appreciate that.
Jennifer.
No.
I'm sorry, I get passionate about it.
They really are passionate about what they do, aren't they? Which is why they're here. That's amazing. Jennifer, tell us a little bit about patients that, Sue alluded to it, they staying at home as long as possible unless
Yes.
they need more attention. Tell us about that, a little bit more detail.
I thought I was supposed to talk about how I was getting paid for it. No. So,
And that, tell us that too.
so
Yes.
hospice, and all of us, if you'll find, CMS, we all do the same thing. It's end of life care. So a lot of, we will all answer these questions. Hospice, there's two kinds. You can have inpatient hospice, or you can have at-home hospice. We go to wherever someone calls home. So it could be their residence, it could be assisted living, memory care, independent living, it could be in a hospital, it could be in a nursing home. If it's in skilled care, it's a little different because we have to have a contract with the skilled care. But that's something on our end. It's not something that a patient would have to be responsible for. So it's wherever somebody calls home, we will go in. Now I'm gonna put a caveat on that. If we go into a home that's not safe for our caregivers, and trust me, if you talk to my team, they've been in where there's been drug dealings. Maybe some of their children still live in the home and they're dealing drugs out of the home. Firearm on the nightstand. There have been some places where, let's just say that State Board of Health probably should have condemned them a long time ago. Now, do we just go like this and walk away? No, we will turn them into the appropriate authorities if necessary, if we feel like that patient is gonna be in any kind of jeopardy. But wherever somebody calls home, that's where we're going. And this
So we
benefit-
shouldn't necessarily expect a skilled nursing community
No,
to do
you
the
just-
hospice work.
We can do the hospice, we can bring in the oxygen, we can bring in the DME. Now, there might be a time
You say
where,
DME, tell me about
durable medical equipment, I'm
Okay.
sorry, that's your hospital beds, that's your oxygen, that's, whatever you might be for your comfort or safety. Safety's a big part of it.
tools and resources.
Tools
Yeah.
and resources. But also, I'm gonna kind of put a little caveat in there. If we cannot manage your pain effectively from your home, then we will suggest inpatient, as Sue talked about earlier. So again, but I would say generally we can provide care wherever you call home. So that whole aging in place scenario. And then we keep talking about the benefit. How many of you have had a job and you get the check and they're like, boy, the government took a big piece of that? Everybody looked at your paycheck and wished you kind of had a little bit of that money back?
Or your kids say, who the heck is FICA?
Who's FICA? Exactly. Who's FICA getting more money than I am? So, yeah, I keep asking who's FICA, why they getting all my paycheck. So you are paying in, every time they take money out of for our friends at FICA, you're paying into Medicare. You've paid for this benefit. You've earned this benefit. So Medicare Part A, Medicaid, if anyone's on Medicaid, this is a benefit to you. If you're on veteran benefits, they will also pay. You have a built-in hospice benefit. If you are under 65 and not on Medicare, most major health plans will cover hospice. So it is a paid benefit. And Kate talked about it earlier too. The sooner that you choose, I mean, hospice is not laying in bed. Hospice is not what I remember as a kid watching on TV where they're like, oh, that long drawn, that's not what hospice is. We encourage you, if you have that conversation with your primary care physician and they suggest that you go on hospice care, don't wait, because there are so many benefits that you are waiting or losing out on. So, and it doesn't mean that you're giving up. A lot of people are like, well, I'm just gonna go lay in bed and die. That was my mom. She fell asleep one night and my sister was there. My sister tapped her leg just to let her know she was leaving, and she said, Mom, I'm leaving. And my mom wakes up and goes, oh. My sister's like, what? She goes, I thought I was gonna see Jesus. And so she was disappointed that she hadn't died and gone to heaven yet. So it was just my sister. So every time I see my sister, I joke a little bit and go, oh. So again, I have patients on hospice right now. They're playing bingo. They're going out to lunch. I mean, they're doing all the things that you would want them to do at the end of life. And trust me, if I'm not playing bingo at the end of my life, I'm going to come back and haunt someone. I just want that on record right now. So, but it is paid for by Medicare. It's paid for by most major insurances, and it can be in your home. Everybody hears this aging in place, and everybody gets nervous. And if you have questions about how you can age in place, talk to Rock. Talk to Mr. Perkins over here, because they can help you and see if you're in a situation where you can age in place. It's never too late to have those conversations.
I want to compound on some things that she had mentioned, staying home. So because of the acuity of some of the hospital diseases and the prognosis of that, it is hard to stay at home. And so one of the areas that our social worker or resource provider would do is, if you're not able to stay at home all by yourself, and hospice is only coming in for a certain amount of time, well then how do I do this? And so then we would put you in resources with other people in the community that would come in and bridge that gap. Very, very often we partner with private caregivers that come in and help, especially if it's during certain hours where people need to rest, then we can bring people in. Aid and attendance is something that she mentioned. We just brought on a family that he was a Army vet and an Air Force vet, 2-time, was not enrolled into the VA. We got him home. He's a Parkinson's. The wife was at home at bedside, and we got him aid and attendance of additional 56 hours a week within 1 week of bringing him on services. So there are so many resources out there to help people achieve what their goals are, that oftentimes this becomes just very deep waters, and people don't know that there's all of these resources out there for you. So that's just another piece. And then the other thing that I wanted to add real quick, there are 4 levels of care to hospice. Okay, people don't know this. There's routine. Routine is when we come to your home, okay? We come to your home and we are on a visit frequency. So your nurses come in a couple times a week. Your aides are there Monday through Friday. Your social workers coming in 1 time a week. Your chaplain is coming in 1 time a week. Then you've got your bereavement after the fact. But all of those, that's called routine care. So oftentimes what happens is Medicare is very smart. I say it's the one thing that the government hasn't messed up yet. Okay, so it's a very rich benefit. What I mean by that is, then they say, well, if you're taking care of your loved one at home, then there's probably a chance that that caregiver is going to get really exhausted. So they created another level of care called a respite, which means that you can put your loved one into a nursing home under a respite contract for 5 days and give that caregiver a reprieve from taking care and to reset, if you will, in a skilled nursing facility. Go on a vacation. Now the caveat to that is it can't be an assisted living. You have to have an RN 24/7. So that's your key component in that, and then again, your resource, your social worker helps with those resources. Your continuous care is your third level. That's where, for example, when I lost my mom, she was a stage 4 lung cancer with mets, widespread. When she ended up passing, her symptoms were unmanageable. So we had to have a nurse that sat at her bedside and administered meds every hour. Now that is something that our team would identify, and we would say we're going to go ahead and do a continuous care, and so then between your RNs, your CNAs, and your LPNs, you create a blanket of consistency and presence until those symptoms are managed. And then lastly, oftentimes, I don't see GIP very often. When I do see it, in my experience, it's typically cancer patients where their pain becomes so unmanageable.
Excuse me, what did you say? Could you tell me what,
Yeah,
Yes.
the acronym.
what's that
Sorry.
stand for?
Healthcare is an acronym world. General inpatient.
Okay, thank you.
And that is when individuals, we contract, hospice companies contract with, I point to Sue over here because she's with community. And then we can contract with the hospital, and then our team collaborates with the hospital team in order to make sure that that family gets the pain management that they need, because that pain management is unavailable at that site. Okay, so those are your 4 levels of care. Typically 90% of everybody is going to be your routine care, which is where we come into the home. But those are just some of the additional information that people don't know
Because the
about.
goal really in hospice, sorry to interrupt, is to be proactive.
That's right.
You know, we don't want to have to chase pain. Our goal is to keep those patients routine. It's the outliers that do the continuous care and the general inpatient care. But, those nurses are trained, the case managers, to see signs and symptoms as the changes occur in somebody, as their disease progresses. So they can be, okay, yes, let's bring in this medication to help manage this symptom before it becomes out of control. Or let's, like you said, the medical director is part of that care team, the interdisciplinary team. Call them up, her or him, and say, hey, what's the best action here? What should we be doing so we don't get into a crisis situation? That's the big thing. And the one thing that I wanted to mention, that something that you touched on, was when your doctor tells you it's time for hospice. I think, don't wait till your doctor, if you know somebody or if you ask them, because that's the one, doctors aren't trained to do that. They'll wait until the absolute last minute sometimes, when it's not necessarily the most beneficial thing for that patient or family.
I was gonna ask you, when do you know? Like, what's
Well,
that
I
first
think
step?
you know.
Look back there, I put like, when's it time for hospice?
Okay,
And that's
good.
not set in stone,
Right.
but that's what we'll give a lot of the, like in assisted living, because the nurses are like, how do we know?
Yeah.
Right.
So that's just kind of a
Guideline.
if you will,
And
but.
it depends on your goals and objectives.
Right,
I just learned this last week. Within the medical realm, and specifically in the Western Hemisphere, we push curative. Death is not celebrated. It's not something that anybody looks forward to, and we push it off like the plague. But what I learned was that, I don't even know if I should say this. What I learned is that there is an agenda to keep people continuing to come back to the hospital and to keep them alive for a certain amount of time before the doctors will give the permission for hospice. Oh, it made me sick.
I mean, some of it's understandable. I mean, physicians go into healthcare to heal people. That's their mindset, right? And that's
Fair.
a great mindset
That's
to have.
fair, if that's their agenda.
But unfortunately, in our healthcare system nowadays, it's a business.
It's dictated by money.
Yeah,
It's
you know.
all about outcomes
So,
and money,
yeah.
and so my point to that is, know what the advanced directives are, and we're going to get to that. Know what your goals are. Know what your goals are, and honor the goals of the people that you love and
Well,
that
you
love
say
you.
goals, but I'm like, I wouldn't even know, like, what are my what are my goals, but what are my options?
It's a
What are
live
my choices?
document. It's always changing,
Right.
right?
Well, I mean,
So
that's
your
why I think-
goals are going to be different than my goals.
Right, and you have to be
Yeah.
proactive in your care.
Mm-hmm.
Unfortunately, that's the situation that we're in. You know, I mean, you have to be on top of your own care. You have to ask the questions. You have to figure out.
Have to advocate.
And Jennifer
Exactly.
said, advocate
Word
for
advocate.
yourself, advocate for your loved ones, and then sit down and have those conversations.
Hard conversations.
You know, I think a lot of people, and I know our parents' generation, that's not something you talked about. You know, you didn't talk about death and dying. You didn't talk about what you wanted to do. You didn't tell your, you know, I don't want them to know what my bank account information is, you know? Okay, fine, I don't need to know it until, you know, but let's get a plan in place, you know? And then, and I think a lot of times people too, and I think we're segueing into
Yes.
this situation of, you know, they think that, you know, if they give somebody power of attorney or a healthcare rep, that they get to make decisions for them immediately, and that's not the case. If you have somebody who has the power of attorney, that doesn't go into effect until you're incapacitated or unable to make those decisions.
You
for
can't
yourself.
make
By
informed
the
decisions.
state.
And I think that you guys could probably attest to that, right? Yeah. So,
Well, if it's a springing power of attorney, that's the case. If you sign a durable power of attorney, then they can still make choices.
See, just when I thought that durable power of attorney was the all, then you teach me a new thing about
Springing is if you reach incapacity. You have to be diagnosed as,
Alzheimer's, for
Right.
example.
Yeah.
then that kicks in. But if you have a durable power of attorney, then decisions can still be made for you.
even when you're alert and oriented.
They can't override
Yeah,
though.
they
If
can't.
you're alert and oriented.
You can
Yeah, you cannot
override.
override you, but yes.
Yeah, okay. Well, that's good to know.
That's very good to know.
Yeah.
So, yeah, write that down, spring.
Oh, I guess, cause we already have power of attorneys, I just need to find out.
How do you use it? Like,
Right.
what is it now? What are the choices? So you were gonna tell, you did a very good, I mean, I really appreciate you saying, the doctor and Kate, like, doctors may not, say the word hospice or educate on, you know, give you that option as soon as.
It goes against their grain, you know, they're there to heal you, they're there to fix you.
Sure it
And they
is.
look at it sometimes, and not all of them, but they look at it as a failure,
Mhm.
you know, I mean, and just,
So that's really good to know, right? Like, that, just that different perspective, that's just how they're feeling because they're trained differently.
right,
But you might be entitled to comfort earlier
right,
Absolutely.
and resources
Right.
earlier.
yeah.
Betsy, I'm just curious, did you know any of that?
No. We got the curative push with my mother-in-law that back to the hospital, back to a new doctor, a new specialist, and maybe this other treatment will do something for her. And a lot of, well, she had Alzheimer's, so her dementia was really advanced. And then when I would see that she was in more suffering than any other thing, confusion and anxiety, stress because she was so lost, they would say, okay, so let's just flush her, like clean off all of her medicines and then start her all over again, and that will help her again. But hospice was not presented to us until I was sitting in there. We did that already and it doesn't help. We tried that, and I just want her to feel peace, to be at peace. And I was able to manage when she was lost in time, and I would find her wherever she was in time and try to appease her, whatever, you know, circumstance she was at that moment, or her brain, what time in her history was she at that moment, and give her some answers, because then she was lost. Like, you know, she was still single, and where's my mom, and where's my dad, and did I get married, and how long did I live with him, or things like that I could find. But I didn't know that we could have asked for all of those things ahead of time when she moved in with us. And it was
I know.
just it was when they were saying like, there's nothing else that we can do, so now somebody came with hospice care. And it was a hard conversation, but because a Zoom meeting with all of her children, for them, it was like, so we have to give up on mom.
It's not giving.
No.
And yeah,
Oh.
so that was the whole conversation, and to me, it was hard that I couldn't understand the fact that I was not trying to, for me, it was hard to say, well, it looks like she needs something to drink. It looks like no, she's not drinking anymore, and to me, it was a hard switching off. I need to take care of her, and for me, it was like, I just need to let her go. And it was horrible to turn the switch off when all I did for her was trying to be there for her and take care of her, and even when she didn't know she was thirsty, because then I knew she got dehydrated, so I needed to push more fluids on her and things like that they said, you don't need to do that anymore.
I always say hospice, because again, and I'll use the phrase, in the Western Hemisphere, it's so focused on medical all the time, but there's so much more to life than just the medical perspective. And I say that hospice comes in, and for just for a second, we put the medical on the shelf, and then we focus on all of the other things that create color in your world. Let's just create color. For whatever time is left, it's not giving up, it's quality.
Mm-hmm.
It's quality versus quantity, but it's that idea that the inevitable is going to happen, whether you want it to or not. And that's where I even call it the H word. Like, let's not talk about the H word, because that means essentially we've given up. And I'm like, no, it just means that we're shelving things that have been such a priority through all of this time. We're just gonna shelf it for a minute. And we're really going to concentrate on and get back to and remember and rejuvenate the areas that we've not done because we've been so focused on this. We have a patient right now, she paints. She would paint Bob.
And I'm thinking how much family time can be happening during that as well.
Absolutely.
All of
That
it.
is so important. We're gonna
Yep,
we're
move
gonna
on.
shoot through
Yep.
some questions. I want to say, okay, so we have a document back here that talks about when is it,
When's the time?
so when is the right time? We know now early, don't wait till the last minute.
Don't wait.
Absolutely.
It's the number one thing that I hear in healthcare and in hospice is that I wish I would have done this sooner.
Amen.
It's the number one thing.
Or
We
wish I knew
talk about that a lot
Yes,
in this
yeah.
group, don't we? Like, plan early, like know what.
Ironically enough, I was in Chicago for the weekend, and I met up with a nurse practitioner, and she had come in from Canada, and she says, hospice, nobody talks about hospice here in the States. Like, it's not even a part of your system. She was blown away by that. She's like, it's such a valuable resource that we rely on all the time in Canada, that when I got here, it was like, it was never even discussed. And it was just another area of awareness, and anyway.
Thank you. Wanted to ask, what happens when someone passes away at home?
Great question. So this is where your social worker is going to come into play. We believe that everything should be seamless and nothing should be a surprise. So we do a lot of planning. I have to ask really hard questions when I meet with families. I've got a really hard question to ask you, and I don't love it. What do you want to do if your heart stops? Well, I don't want to be, and people are typically very clear on that. I don't want any of this. So I'm like, okay, so we've got a DNR in place. That's really important.
DNR means do not resuscitate, if you didn't know.
Post, yeah, sorry. Let's just go for order. And then it says, okay, my next question is, what are your arrangements for funeral? So we always talk about these things in the very beginning, as difficult as it is. And most of the time, people are very transparent about that. Like, I'm not stepping on anything. They're like, yep, we've got arrangements, here they are, and they give us everything. Or they say, we haven't thought about that. And I say, that's okay. So we're going to start having these conversations, and then our resource provider, our social worker, starts having those conversations in order. So when somebody goes home, when somebody dies at home, Depending on if the RN case manager is there or not, you would notify hospice. We now become your 911. As soon as you sign those documents, hospice becomes your new 911. So if anything happens, you call us and we should come out to the house. That needs to be clarified. So in the case of somebody passes, you would call us, our nurse would come out, we would prepare the body, we would wash and prepare, that's honorable. We would call the time of death for the documents. We would call the funeral home. We should wait for the funeral home to get there. We should help in any capacity that we can. We would sign a transit form, give that to your funeral. They take that, they take the remains, they pass, and then the funeral home is in charge of getting your attending physician to sign the death certificate, and then you would get released a death certificate, or whoever the POA is. So that's an area that creates a lot of, believe it or not, a lot of noise. If you don't get that death certificate as the POA, then there's a lot of things that you can't do. So it's really important to understand what that process is and who is leading the conversations on that. And so, but that is what it looks like when somebody should pass at home. We always invite our chaplain to come out. We call our chaplain, we call our social worker. Nothing that we do is transactional. So by the time this comes to place, you've already created a rapport and a relationship with the majority of our team. And now they're not just titles, but they're people that bring comfort and peace in these times in order to get you through this, because it's a rite of passage and it's very difficult.
And we don't try to rush anybody to, if you have family coming in and you need to wait, we let the funeral home know it's gonna be a couple hours. Cause it usually takes the funeral home a couple hours to get there anyway, but,
This is true.
take your time, say your goodbyes. We wanna honor and respect that person, treat them with dignity. If they're a veteran, we wanna make sure the funeral home's aware of that, they'll carry the flag. Just treat it with the dignity that it deserves.
Yes.
Yeah.
Can I ask a question,
Good.
from a legal perspective, when my father passed, the family was concerned about, the protocol for getting a death certificate executed appropriately. I think that what ended up happening was that they called, a EMT team, and an EMT team came out and agreed that he had passed, and then a physician signed off on a death certificate. But I was thinking that, isn't it important, because the death certificate is so important for managing the estate.
Right.
Everybody and their brother wants multiple copies of
Right.
death certificates, and it's a situation where you wanna make sure that that's absolutely buttoned up. But I was wondering, from what you were saying, that the engagement of the funeral home happens after my understanding happens after the death certificate has been signed, so that they're kind of like able to be released to a funeral home. Is there any kind of sequence going on there with regard to?
Because you're Kate talking about when you're under hospice, and then Jen, you were gonna answer that question, what happens if they're not in hospice?
So, I think the question was framed as unexpected death.
Right.
Okay.
So you hear that, they passed away in their sleep, they didn't wake up. So unexpected death means that they're not under doctor's care or on hospice care.
Okay.
So they're, in Indiana, and it could vary state to state, so in Indiana, you are to call 911. Now.
Is that to engage the coroner?
Yes, so, because also, there's two things to keep in mind here. Do not touch the body, because they're gonna call off the police, because if it's unexpected, they'll probably call the police to make sure that
Natural causes.
it was natural causes. Also keep in mind too, after you call 911, if you have a do not resuscitate order, or if you do have a request for go get that paperwork. The EMT is required by law to do CPR. Now, if they have been deceased for a period of time and nature has taken course and rigor mortis or whatever said, they're not gonna do CPR, but you have to call 911. Do not move the body. Believe it or not, it's a Class B or Class D felony If you do not report the death, it is also a felony. So just if someone's passed away, call 911. In that period of time, you're going to get any information you can, get the DNR or the advance directive, as they're called. You're gonna get a list of medications, so make sure you always have your list of medications where someone could find them. And then any health information that you can find, because they're gonna need that when they come. So the police is gonna come and make sure it's a natural cause and then you didn't put a pillow over your husband's face. I didn't say that out loud, my husband's on good terms with me today. So they're just gonna make sure it is natural causes. And then they will probably call the coroner if they, like in this situation, they were confirmed by the EMTs that they would have passed. So they, instead of taking them to the hospital, they can have the coroner come out and call the time of death, because they're not under hospice care. So they would call the time of death and then release that body to a funeral home. However, the EMTs, after the police have asked their questions, the EMTs have done their part, there is a potential they would take them to the hospital, in which time they will call the time of death and release them, depending on if the coroner could
So
come
would
out.
that be the EMT responders taking them in an ambulance to the hospital for them to do the death certificate at the hospital?
The death certificate, 99.9% of the time, is done by the funeral home.
Oh.
So the
okay.
funeral home will do that. So the either the coroner or the physician will sign off on the death.
Through the Department of Health.
Yes.
Right,
Okay,
That's-
so then
that's
that's
where
where
the
you would
coroner
go
would-
to get
Yes.
additional copies.
right.
And usually the funeral home will be like, how many copies do you want? And then of course they're gonna charge you for every.
But what I'm hearing
copy
here
you
that
request.
is an important distinction is that, like, my father was under hospice care at
Yes.
home.
Yes.
When he passed away, and we knew it was imminent, but it happened in the middle of the night, and the family ended up calling 911. And
Should've called, yeah.
They came out and did their routine.
Yeah,
You know, and what I'm hearing here is they probably should have tried to
should've called
engage the
hospice.
hospice care first, rather than going through the situation of calling the EMTs. and having
Exactly.
them do it.
And that's what we tell our patients upon admission, we tell the families too. I have magnets back there, we give everybody a magnet, put it on the refrigerator. So whatever family member is responsible for caregiving at that time, if anything happens overnight, including death, call our office, cause we're 24/7. Vacation, Thanksgiving, we're 24/7. Christmas, 24/7, we are on call,
Or your
so.
911.
And that's
Yeah.
that's the
There's no
only
weekends.
service that we got from hospice. It was the person who came once a day and then they just told us if something happened, call us. And that was it. All that we got is that the knowledge that we had to call them, and then the person who came every day, and of course, everything else, the meal support, the calling the family, keeping them in my house, and psychological, spiritual, all of this, we had to figure out
I'm
ourselves.
sorry, shouldn't have been that
Yeah.
way.
And that's why we did not use the first hospice company that we started with.
And that's why I created my own.
Yeah, and that's why I'm.
Which
where
brings
I-
me really to a good point too, is do your homework.
Yeah.
If you're gonna, cause there's a lot of hospice providers, especially in central Indiana. There's a website called, or hospicecompare.gov. There's one for, nursing homes, it's skillednursingcompare.gov, or you can look up doctors, you can look up hospitals, that's part of that IndieGov thing, and look them up. Yelp has reviews.
Google has
Google
reviews.
has reviews.
But I'm gonna say something real quick and not to interrupt. Remember, reviews are only as good as the people that give the review. So how many times have you looked at a review for a restaurant and everybody's raving about that restaurant and you go and you're like, oh my goodness, what were these people thinking? So of course, anybody that they have a happy moment with, they're like, oh, would you please put a Google review out for us?
Yeah.
So do your homework, ask if you can talk to, cause we have some, patients who have passed and their families are like, we would love, to talk to any family that has questions. So, or
And different hospices offer
Exactly.
different things.
Absolutely.
You know, like some hospices have music therapy, that might not be
Yep.
for everybody, but if you have a dementia patient, that might be a wonderful fit for you. Some hospices offer massage therapy, might not be for everybody, but maybe an ALS patient, that would be wonderful for them, you know? So interview the hospice providers, to meet with somebody like
Yeah.
Jennifer or somebody like Kate or myself, you know, and see how you know, how you get along. Because I think a lot of times, how you kind of, you know, communicate with somebody and you kind of get that feeling, I know I'm gonna feel comfortable with this person and what they represent. So yeah, do your homework, meet with people, you know, and figure out what's best for you and your family. Because that's what's most important in the
This,
end.
there should be nothing transactional about this.
Right.
So when you interview people, it should be a feel.
Yeah, feel, that's the word.
You just
Amen, yes.
You just know, and
I like knowing that they're not all the same too.
they're not the
So,
same.
Somehow,
I
yeah.
think that's a great, depends on what your goals are,
Right,
Kate has said over and over again, but then knowing that there are some, resources that are available at one resource and not another, so.
Yeah,
super
absolutely.
helpful. Yeah.
Somebody said you can get multiple death certificates from where?
You would call the Department of Health.
Yes.
Okay.
Or, sometimes the funeral homes will be working with the families and they'll say, if it's a good, I always say, if it's a good funeral home, they'll say, how many copies do you want?
Yes.
And they'll go ahead and do that homework.
Okay.
And get a lot.
Yeah, like 10.
Yeah.
That's good.
Lisa.
So a question on, when you're in hospice, you know by the time you get to hospice, we've all collected a bunch of doctors in our lives, right? Do all of those doctors go away?
This is a great question. It's family choice. You get to choose who you want your attending to be. So when you sign up,
have an age of what primary attending.
so when you sign up for hospice, there's gonna be caveats to this, and you're going to want to listen very carefully. People do not want to break up with their primary care physicians because their primary care physicians have been in their world for 30 years. I always say, typically, if there's a family that wants to use their primary care physician and we call that primary care physician, hospice is its own specialty, okay? And so typically, almost 99% of the time, that PCP is going to say, we want to collaborate with this hospice team, but we do not want to be the attending. Because when they are the attending, there's all kinds of responsibility that comes along with that, along with taking phone calls in the middle of the night. So that's where when you have these PCPs, it's always my recommendation, unless the person that they are requesting has done this before and they wanna be a part of this, right? You've gotta get that permission, because they're also going to be the ones signing the certification of terminal illness, which is a huge piece of the hospice component. So typically what I find is you use the hospice's medical director for the attending, because this is his specialty and this is what he signed up for and he knows all of the things, that when you need to have the really important things, this is his jurisdiction, so to speak. But then the hospice company should be sending that updated plan of care, which is something else that we didn't hit on, that updated plan of care every 14 days to that collaborating physician. So they're still being included in the loop.
Okay, and then what about all the specialists? They're gone?
Bye.
Pretty much because you're not doing curative treatment anymore, so you'll have your primary care physician, as she said, usually the medical director for the hospice, and then they will collaborate with your.
Now, that being said, if you go to a podiatrist, you can still go to the
Yeah.
podiatrist. Anything that's not related to your terminal diagnosis, you can still go to. Like, if you're on for, you know, I don't know, cardiology, you know, you have a heart failure or something of that nature, and you can still go see, you know, an optometrist, all these different types of specialties that aren't related, you can still go to.
And then you said the medical director becomes like your primary care physician.
Yes.
Do they come and visit the patient
They can.
regularly?
Mine
Sometimes.
has.
Absolutely.
Yeah.
Okay.
Absolutely. They're the ones that are gonna write the prescriptions for you. Very common, and these gals might laugh, but UTIs are very common. And so they'll write the prescription for your UTI, urinary tract infection. you know, those kind of things as well.
So we have a medical director and then we also have a nurse practitioner. And so our nurse
Could be the nurse
Yeah,
practitioner.
so our nurse
doing
practitioner does the
nurses.
majority of the house visits, but Dr. Ion has also done home visits.
Okay.
And that's going to be different from every single hospice company that you interview.
One thing that I'd like to mention too is, as Kate mentioned, interdisciplinary care plans happen every 2 weeks. Part of the regulatory guidelines from the Center for Medicare and Medicaid, CMS, is that the hospice interdisciplinary team meets every 2 weeks to discuss every patient. And I recommend that if you're able to join into those, that you're, you know, you are, have the right to be part of that conversation. And I love those meetings because that includes all the disciplines that are involved with your loved one or whatever, and kind of talk about what's working, what's not working.
When
is this
when
working?
else in your whole life has anybody ever had an how do you say that?
Interdisciplinary.
Interdisciplinary perspective. I mean, we have troubles, no offense, but like attorneys, you know, and wealth managers talking together, and you know, our doctors. I mean, it's just that's amazing, and I just feel like that doesn't happen enough.
It illustrates Kate's point about wrapping your arms around the
Yeah.
patient and family, and that it's not just about the clinical piece, it's about the whole.
And the medical director is on that call as well, so you can ask questions, you know, there's, especially with dementia patients, I think they're starting to exhibit more behaviors, you know, and we don't want to medicate them. Any suggestions? So then it is a whole team conversation around one patient. So we don't lump a bunch of patients in and say, here we go. We go through each patient one by one, and it's, you know, if you join to talk about your loved one, we'll set a time and we're going to talk just about your loved one. So these calls sometimes go 3-4 hours because we are talking about each patient. And all of us on that interdisciplinary team, we will discuss what's going on with that patient. Sometimes there's no changes, and we can kind of go through and say no changes, but you know, the social worker might say, we're noticing that there's more loneliness. What can we do? Oh, the volunteer coordinator says, oh, you know what? Why don't we ask the family if we can send in a volunteer? Or they love dogs. We've taken a dog in to be with the patient because she really missed her pet that had passed away years before. So we literally go nitty gritty. I'm still looking for the one patient who wants to go skydiving before they're in a life. So if that's any of you all, come over on, you know, I want that big no.
Sue, you mentioned the regulatory agencies. Is there anything out there, and this is a big what if, with the discussions on healthcare costs and healthcare changes and, you know, if this Obamacare goes away or whatever, any of those discussions gonna blow up your world or make anything big differences for us?
It shouldn't, I mean, the only thing that'll change with, if, let's say, the subsidies for, the Affordable Care Act go away, right? That is not gonna make any difference in terms, if you qualify for Medicaid, you still have the hospice benefit. Medicare still has the hospice benefit. Private insurance is what's gonna be affected, right? So people that aren't old enough to qualify or make too much money to qualify for Medicaid, they might be paying out of pocket. But I know that a lot of hospice companies, I'm sure that both of these do, will take on occasional charity care. I know that when I worked for IU and St. Vincent's, they both did that, and I know Community does that too. Now, you know, it is a world that we live in, you know, we can't do all charity care, but that is available to some people, definitely. So you do have to do some paperwork for that. But I don't think that is gonna change for us anyway.
So there's no current conversation. We all stay up on the different regulations that are under discussion. There's no conversations right now, but I'm gonna just put the caveat out there as well. We don't know, because there's a lot of things that are happening now that we didn't expect. But as of now, there's no dialogue that the benefit would ever go away.
Well, and I hate, in my world of hospice and Medicare, I always like to live in the cloud that hospice was created because it was the right thing to do for people at the end of life. Medicare has all of your best interest in mind, and so that's why they created this awesome benefit.
You're so cute.
I know, and I like my cloud, okay? I like living in my cloud. The fact of the matter is that there are billions of dollars saved when people stop seeking aggressive treatment And so for them to offset and say we're getting rid of the Medicaid bit or the Medicare benefit for hospice, will then just jack or increase or multiply all of the costs within the healthcare arena. So it does not do them any benefit to get rid of the benefit from a cost savings aspect.
I do have one more quick question, and I'll just let you ask your question. I'll ask my question, then you ask your question. We have Indiana State and Elder Law in the room, and we also have Alex with Perkins Wealth, who do work really well together, who do communicate well together. So I can't not ask about documents that are needed. Like what happens if we don't plan? So I was gonna ask Sue that question.
Yeah.
And then we're gonna talk about documents. So just know that's coming, but first I'm gonna let you ask your question.
You may wanna go ahead. Medicare will not take away, in my opinion, will not take away hospice. They will stop paying.
Oh.
Maybe.
They could,
I mean, that's what they do.
but I think they saw the benefit recently and gave us an increase
They lower
in
the
payment.
payment, and they've done that a lot.
Yeah.
They do.
And so that's the problem. The other thing, this is where you should have left the meeting. I'm a retired family practice physician in hospitals. And I would like to defend doctors. And I know it's all said, my wife does it too. You don't know how to talk about end of life. You don't do this, you don't do that. Well, my brother was a hospice director, actually. Talking end of life, especially as a hospitalist, you get this patient that drops in there that you've never seen before, that, and you say, your heart stops, do you want us to bring us back? Well, the answer is usually of course, and then you go into another spiel about we're gonna break all your ribs and you're gonna be on a breathing machine. And most doctors that I've worked with, and may just be a select group, are that way. And the families are the biggest problem.
That's a good point.
I've had
When did I?
one patient that was curled up in a little ball, demented, was tube fed, 90-some years old, and every time she came in, she would respond to CPR. It was just awful. I mean, the staff doesn't like doing it, and
This is leading to her next
It
questions, I
is.
think.
Yeah.
and the thing is that her daughter said, no, we're gonna do everything we can to keep this woman alive. And so she was resuscitated multiple times.
I think that really
Some
shows
unfinished
the
business
importance
there.
of having the conversations,
Yeah.
Now,
talking.
the other thing I'd like to say is, being in family practice, you've known these patients usually for a long time, and you start talking to them and the families. And when you say hospice is there, it's a really good thing, and I believe it is, and I pushed hospice both places. But again, it comes down to the family, because you're going in hospice. That means you're going to die. I think that I'm going in hospice, that term needs to.
And that's what we're trying to do, is break that misconception.
So I would talk with them, some would do it, some wouldn't. We had a couple of really good hospice places when I was practicing. But when you try it, and as you say, we were trained to keep improving people, and like with dementia, the first thing you should do is stop a lot of their medicines. And so if you go to a new doctor, they're gonna look at them and go, no, we're gonna stop them, and somebody said, well, we've done that before. That's when the hospice conversation has to start. But I just have, the doctors, especially the newer ones, are more likely to generate those discussions.
Well, it's not something that in med school that you really talked about, was it?
Not really. You wanted to, especially med school, you wanted to
Don't you love the family when the siblings don't agree?
Thank God we both agree.
You guys are.
The sibling, what I found was a sibling who lived the farthest away and was less involved with the parent, was the one.
Was the most
who-
annoying.
Yeah.
And
Yeah, we
so-
get them in the room, and that's where our social worker comes into play.
Yeah.
So
Yeah,
it's,
actually, fist fight.
it's a hard conversation, and there are doctors out there that do a good job and will decrease medications, but again, the family says, why are you stopping this medicine they've been on for 30 years? Well, because they don't need it.
That's great.
So one of the,
So anyway,
Thank
but I
you.
have more questions.
Is it Dave?
You shouldn't have,
Dave?
Dan, yeah,
Dave.
you shouldn't have let me talk.
So I've shared a particular book with a number of aging clients, and I've shared it with a number of estate planning attorneys as well, and I'd be curious to hear your perspective, but Being Mortal,
Yeah, I read it.
by Atul Gawande.
Yeah, it's a great book.
It's a fascinating read,
Mm-hmm.
and it was just all about talking about what do you want later in life, because it's the profession is all about keeping people alive longer and longer and longer without addressing quality of life. And so it's one of the examples that was discussed in the book. There's a number of stories. Was about a father and a daughter talking about a high risk surgery, and so the father and the daughter were talking about it, and the daughter asked, well, what would be success to you? What would be success out of the surgery? And he said that if he could eat ice cream and watch football
Yeah.
after it, then it would be deemed a success. And so the daughter was like, all right, now I know. So whenever the dad went to have surgery, the surgeon came out and said, hey, we're at this critical junction, should we pivot or should we keep going? And so the daughter asked the surgeon, what's his likelihood that after this, if you continue on this path, will he be able to watch football and eat ice cream? And he said, I mean, it'll be some very hard months, maybe a year of intense therapy, but yeah, there's a high likelihood. And so she gave the okay to keep going.
So
Well,
having
but-
those conversations.
What made you read that book?
My brother is a surgeon, and so he
What was the
said,
name of the book?
Immortal.
Be immortal.
The other thing, I think medicine's biggest, one of its problems is saying no to a therapy is a valid decision.
Sure.
And when you make that decision, you've made your best decision because you've closed all the other pathways.
Right.
And so saying no to, well, it works with not going to the hospice, saying no to surgery is a valid decision, and that's the one it's gonna be the best one for you. And that's something that's hard to take as a doctor. You'd like to sell them on what you see as a better thing. Hospice and palliative care is a wonderful, wonderful thing. It just has a bad reputation.
It does.
And when even with the documents, when you're laying on the bed gasping for breath and you say, do you want to be put on a respirator? Yeah, this time. They override.
That's fair,
And
yeah,
believe
that's
me,
fair.
as a doctor, I don't wanna do all that work.
Yeah.
'Cause
Yeah.
I don't wanna kill you, but I also don't wanna do all the work too, if I can avoid it.
Let's talk about those documents.
Well, if you don't have any documents, if you have not had the conversation, you don't have a living will, you don't have a do not resuscitate or a post form, then the EMTs or whoever they are legally obligated to perform CPR.
Can I mention one thing to follow on to that is
Yeah.
that I've worked with the elder law care and done all the documentation. The hospitals will not recognize legally notarized documents unless you file forms in their system. Because if you show up at their front door and say, I have an executed, do not resuscitate, if it's not logged in their system, they won't honor it. So you need to get in advance with your healthcare systems, make sure that you file the paperwork and the forms within their Epic and other systems so that they recognize when you show up that you have on record what your wishes are. Because even if you have legally recognized documents, if you don't fill their forms out, they won't necessarily actually.
They have have to recognize those. They don't have to be on file because you could
I mean, it could be
go to a
personal.
different hospital than what you typically
Here's the
would go to.
pushback on that, is that the hospitals will argue that they're not lawyers and they don't know whether or not that's the most current version of a last will. So unless you have something in the hospital system that accompanies a PDF of the actual document, they may contend that, well, we can't determine that that's the current legal standing
Right.
document.
So,
So, in reference to that, my question is, if you, your primary care physician, if they have copies of all of that, would that document then be legally acceptable?
It's the medical system, like, for example, community or IU, what your primary care physician, what his relationship is with that system,
Okay,
whether or not he, from his office, acknowledges in that system that you've shown these documents, and that
Okay.
he has on file that you've produced these documents. If the hospital system doesn't know or hasn't received some formal notification through their own system, then they're gonna be in a situation where they have to be suspect about, well, how do I know that's not an expired will and something else has come along?
so case in point, I have an assortment of doctors for different things, from cardiologists to OBGYN to, all of these doctors. They don't all have privileges, I think is what they call it, with different hospitals. I have a hospital that if I'm gonna be in an emergency situation is my preference. But it's not, my primary care physician doesn't necessarily, so my question to you is, do I go right straight to the hospital and say, hey,
Yeah, I
Here's a
think like
copy.
with community, you can go online and ask to fill out the documentation and
Okay.
file it with them if you're under their network.
Sure.
And again, it gets back to like the PCPs and what their relationship is to the networks that you're wanting to work with. So you could probably have a scenario where a PCP isn't affiliated with the hospital that you prefer
Sure.
to go with. So in that instance, you gotta make sure that you work within that hospital network's protocols.
So at what point do we start carrying our documentation with
Yeah.
us on regular?
well, it doesn't matter.
My
sometimes.
experience from, I worked at IU, was if, 90% of the time, your physician, your primary care physician is an IU doctor then, right?
Yeah.
You go to an IU hospital, but even, so they're in the same, they use the same. Network, right, and they can see all your documentation that's pulled up. But if you're going to, let's say, community, because it's the closest hospital in an emergency situation, they can still do a post form right then and there, and you can tell them what your, wishes are, at that point.
If you
you're
are
able to-
conscious.
If you're
Like if
conscious,
it's
right, or
required.
if you have, if you're not conscious, I would think that you might have somebody with you. Now, if you're on the street, and nobody, let's say you just had a heart attack or something,
Yeah.
nobody knows who you are or whatever, then they're gonna do whatever. They're gonna do what they have to because they're legally bound to do that, right? So again, just goes back to have the conversations, document your conversations, update them, like we talked earlier, like, we've got the new year coming up. Maybe make that a conversation that you have, the week after the holidays or the first week of the year. Let's sit down with my family and redo this every year because your goals will change every year. As we age, we have different things. Yeah, in my 50s, I wanted to do this. In my 60s, I want to do that. When I get in my 70s, I might carry
Are you
back a bit.
skydiving?
Yeah, me, oh my God, yeah. Those kind of things, so as we age, priorities change, or, our health changes, so we have different goals, so continue to update those documents.
What are those documents?
Yep, what are they?
Well,
So
maybe-
you're gonna have, go ahead.
Oh, yeah, which that's a great point, thank you for bringing that up. I actually have a blog article back here if anybody is interested, that kind of talks about like how to have those conversations with your families, especially now. Typically, people are getting, ready to have family gatherings, right, in the holidays and things like that, but what we call like the core 4 documents, so it's your power of attorney, your living will, your last will and testament, and then your healthcare directives or your healthcare power of attorney. So those are like all of your main core 4 documents that kind of get bundled up into your.
Perfect.
And then also, one of the things I was telling Lee Ann when we were preparing for this call, I have hospice in my advanced directive. So my
Yes.
family knows that I want, if I get to that point where hospice is necessary, that I want hospice. So you can put that you want to be under hospice care. And then I was also so it's hard to have those conversations. Grab one of those, I haven't read her blog,
Yes.
But I had a dad who had he's still living, stage 4 kidney failure. My mom was diagnosed with early dementia. And so they live in Florida, and I went to Florida and had to have, hey, how's things in Florida, by the way? And started having those hard conversations. But it was, Dad, do you want Mom making healthcare decisions for you when she has early dementia? Oh. If you have to be put in assisted living, do you want to be in Florida or do you want to come back home to Indiana? So that way we were having those conversations. It wasn't easy to have, but they were more receptive than I ever thought they would be. So whether you have them with your loved one, and also one of the things is you don't want to be in crisis mode.
Right.
No.
There is nothing worse than trying to make decisions when you're in crisis mode. What hospice, what home care, what assisted living,
Oh, and
what
it's
hospital.
guilt. It's guilt ridden.
It is, and
Am
I don't wanna
making
do
the
that
right
to my
decision?
kids. So I have created, and I said this binder, and I'm not gonna tell you the name of the binder, cause it's not quite good to say, especially in the midst of a chaplain back there. But it's, now that I am gone, here's the blank that you get to deal with.
Oh, yeah.
And so, yeah, it's yours to say. So the binder has anywhere from our life insurance to the deed to our home to the, any of the auto documents that we need. You name the document, my kids aren't gonna have to rifle through files and try to figure out what they've gotta do when we're gone.
There's a book out there, I'm Dead, Now What?
Now,
Yeah.
very similar to that. So it's all in this binder.
I like your title better.
You know what, we get down to the nitty gritty, we tell the truth in my house. So, if you can't, one, have the conversations, as Sue said, but number 2, just put it all, or like my dad, he's like, I've got the documents of how, what I want for my funeral, and it's in this folder, and the folder's on my desk, and this little filing thing. So, just have the conversations, because you don't want it, the best thing you could ever do for your loved ones is to help them make decisions for you.
Absolutely.
Before they're in crisis mode, because when they're in crisis mode, they're going through ups and downs of emotions, they're grieving, they're doing all of those emotional things. You don't wanna add to that burden. Ask Betsy back there. Betsy it sounds like she had to figure this all out on the fly.
And I don't wanna do that to my kids.
Right.
I don't wanna have them make those decisions, and put them in that spot or whatever. I wanna make it myself.
Look, Carmen's
I
planning.
wanna make those decisions for me.
Carmen's here tonight, today planning, because,
I'm sorry.
she's asking the questions. So it's a huge gift to have these plans.
It's
for-
been a push-pull all year with my parents. They're down in Florida, and it's time to bring it back up. And every other month, it's one wants to come, one doesn't.
And my dad wanted to stay, mom was ready to come home.
And dad has vascular dementia, and mom has MS.
Oh,
And so it's just been, and I've been begging for certain things for so many years. And mom the other day was like, oh, now I know why you need this. I'm like, give it to me. Just let me have the document. And my sister and I are attending their doctor's appointments via phone. So, we're doing what we can,
It's a fine line, because you don't wanna take away their autonomy.
Right.
You wanna respect their dignity as people age, just because they're getting older doesn't mean they can't make a decision.
I told them,
You
you
know?
gotta tell me what you want.
Right.
And that's the
It
thing,
sounds
is I
like
said,
you need to get Jen's book.
Yeah,
For sure.
I said,
Your
I'll
binder,
do whatever
yes.
you want, but you have to tell me
Right,
what you want
exactly.
first.
Yeah.
Well, and this is where you see the flip, right? So it's really easy to go through life and you've got parents and they're always telling you what to do and they're the ones making the decisions, and then something flips and now the children become the ones that are making the decisions, and that's not the natural way of things. So it becomes very convoluted and confusing and emotional. And you wanna give them autonomy, but you know what's best for them. And so it's this dance that you are now partaking in, whether you wanted to or you didn't. And so.
All year.
Well, we're
So
gonna
do
go
the
ahead, and wrap up. I definitely wanna encourage you to stay and talk to your experts. But before we wrap up, you do have a flyer in your seat for December 15th talk on the moving process and how to simplify it. And then please remember to complete your survey. You can hand it to myself, Betsy, Rock is always helpful collecting those things, or Kayla. So if you would please fill out the surveys and leave that behind. And Thank you again.
Thank you.